Hi, my name is Renee Trinidad Martinez from Chalk Children's Hospital, and I'm going to discuss the LISA procedure, also known as less invasive surfactant administration. Before we start, let's talk about the purpose and indications for LISA. Purpose. Research supports surfactant administration within 2 hours of life for intubated patients in the delivery room or as soon as possible after intubation in the NICU. For patients with respiratory distress syndrome who are not intubated, for instance babies on CPAP, but require oxygen to maintain saturations greater than 92%, LISA is indicated. The purpose of less invasive surfactant administration is to prevent CPAP failure in infants with RDS by providing surfactant therapy in these patients while maintaining spontaneous breathing without requiring intubation and mechanical ventilation. This procedure is performed by placing a thin catheter below the vocal cords using a laryngoscope to administer surfactant into the lungs. Algorithm. This algorithm will be placed at the bedside upon admission, regardless of gestational age. We will use this algorithm to determine which infants qualify for LISA. Inclusion criteria. Patients that are less than 26 weeks of gestational age on oxygen greater than 21 to 25% in the first 6 hours of life. Patients 26 to 28 weeks gestational age on oxygen greater than 30% for the first 12 hours. And lastly, patients greater than 28 weeks gestational age on oxygen greater than 35% for the first 24 hours. Exclusion criteria. Significant established RDS requiring intubation and mechanical ventilation, so those on oxygen greater than 50% or PCO2s greater than 65 millimeters of mercury. Significant apneas requiring intubation or other causes of respiratory failure with no RDS on chest X-ray. Now that we know the indications and exclusions, let's go over the preparations needed for LISA and the steps for the procedure. We will start with the supplies. You will need a 16-gauge angiocatheter, measuring tape, a laryngoscope and an appropriate sized blade, tape to mark the catheter depth, surfactant pre-filled syringe with T-connector, and the dose for that is 2.5 milliliters per kilogram. Equipment for manual PPV and emergent intubation. For example, a neopuff, suction catheter, ET tube, CO2 detector, and a TCOM. Next, we'll talk about measuring the catheter depth. You will remove the needle from the angiocath and discard it in the sharps container. To determine the length, you will use the measurement of 6 centimeters plus the weight of the baby in kilograms. In this example, we're using 1 kilogram as our weight, which makes our measurement 7 centimeters. You're going to place the tape on the catheter to mark the depth. Medications. Ensure that caffeine was given per protocol. We will give atropine the dose of 0.02 milligrams per kilogram for bradycardia and administer this 2 to 3 minutes prior to the procedure. We will give oral sucrose before the laryngoscopy. And lastly, fentanyl is optional and the dose is 0.5 micrograms per kilogram, given over at least 5 minutes, 2 to 5 minutes before the procedure is done. Once the supplies are prepared and medications are administered per checklist, the procedure will proceed as follows. Place the infant in a developmentally appropriate positioning with containment. Position the neck in a sniffing position and avoid hyperextension. Remove chin straps and maintain CPAP interface, which is the mask. Give your sucrose to minimize discomfort. Ensure the bubbling of the CPAP, and you're going to monitor the vital signs by activating the monitor QRS volume on the screen. And then next, the provider will visualize the cords using a laryngoscope. Insert the angiocath and advance to the pre-planned depth measured by the tape. Hold it throughout the procedure and then close the mouth and ensure that bubbling is obtained. Next, you will connect the T-connector to the angiocath and slowly instill the surfactant over 1 minute. This will be given in 4 aliquots with 10-second pauses in between. Followed by a 2 milliliter bolus of air to flush the catheter. Remember to provide gentle tactile stimulation during surfactant administration to encourage spontaneous breathing of the baby. Lastly, you will remove the catheter. Post-procedure. After the procedure is finished, the team will debrief and discuss areas for improvement, if any. This is the time to wean the oxygen as tolerates. If no improvement of FiO2 within 30 minutes, check gastric aspirate for surfactant and consider redosing. Notify the parents within 30 minutes of the procedure completion. Document the procedure in the EMR. And lastly, take note of FiO2 pre-procedure, then 30 minutes after, and 60 minutes post-procedure, as well as any complications.